Good morning, everyone, and welcome. We're delighted to be hosting this webinar as part of the London Festival of Architecture with this year's theme of care. My name is Michael Woodford. I'm a partner at White Arkitekter and director of our London studio. The theme for this morning's session is why we must revolutionise the workplace for healthcare workers through architecture, a theme that we at White have given great consideration when delivering our many healthcare projects. This theme is particularly important to discuss at this time, with reports of the vital role of our key workers filling the newspapers every day. Alongside this, the government is currently undertaking a significant programme of healthcare investment, with new hospital proposals coming forward across the country. Society and us as designers have a responsibility to give our key workers the best environments possible to do the vital work they perform. For healthcare workers, nurses, doctors, hospital porters and cleaners, this means designing the very best hospitals that promote the mental and physical health and the morale of staff so they can perform their roles in a way that is supported by functional, sustainable and well-designed architecture. It is very important to be aware of the stress and strain that healthcare staff are under and the potential of the workplace to reduce stress and promote well-being. Things such as daylight, fresh air, access to outdoor space, good acoustics and inspiring spaces can make a huge difference. It is our responsibility to create environments where staff feel comfortable working and empowered to adapt as the situation demands so they can act in the best interests of their patients. If we don't do this, we will lose our valuable key workers to other sectors. In March this year, the Institute for Public Policy Research published a report that 1 in 4 NHS workers are more likely to quit their job than they were the previous year. This was primarily due to work pressure, low pay and lack of staff. The report called for better pay, benefits and flexible working with less admin. In response, the UK government made a disgraceful recommendation that the healthcare staff should receive a 1% pay rise. Adding to this complex situation, we have to live with Brexit and the associated issues with staff recruitment and retention within the sector. Across the society, since the COVID-19 pandemic started, there's been a significant shift in the workplace, with the government instructing us all to work from home when we can. New technologies and online platforms, collaboration tools have changed the working environment forever, with an increased focus on flexibility and well-being. To discuss this most important of topics, we have 4 fantastic speakers. Ruth Charity from the Oxford University Arts Coordinator. Ruth, she's a contemporary art curator and commissioner for healthcare environments with over 25 years experience, founder of ArtLink, the arts programme for Oxford University Hospital's NHS Foundation Trust. Through this organisation, she's commissioned site-specific artworks by artists such as Michael Craig Martin, Jan van Hollenben, and Susan Morris, among many others. We also have Jonathan Erskine. Jonathan is Executive Director of the European Health Property Network, a non-profit foundation that brings together a range of public and academic sector organisations with common interests in how to best plan, design and build and finance healthcare buildings. Kevin Bates. Kevin is Director of Scottsdale and Walker Architects, recipient of the RIAI Triennial Gold Medal for Excellence in Architecture. He has extensive experience delivering highly complex projects across multiple sectors, both nationally and internationally, including the award-winning Tyndall National Institute for the National University of Ireland. And most recent projects include the Grafton Way building for UCLH. And to start this session, we have Charlotte Rubin, architect and partner and head of healthcare design at White Arkitekter. Charlotte is member of the evaluation committee for the European Healthcare Design Congress and an NLA expert panel member for the healthcare programme. Charlotte was head clinical architect for the new extension of the Karolinska Huddinge project and one of the lead architects behind the pioneering new Karolinska Solna project in Stockholm. Charlotte will put forward a case for the importance of the built environment for staff through the case study of the Karolinska Huddinge project, one of Sweden's largest, most comprehensive surgery and intervention units, planned and equipped to support the very latest in advanced treatment methods. Over to you, Charlotte.
Thank you. Nice to be here, and hello all participants. I will share my screen, and there we go. We go into this view. Excellent. There we go. So I will navigate you now through this projects that I've been engaged with that is referring to this theme. And during the last decade, huge investments are being done in Sweden in new healthcare facilities for the same reasons as now in UK, with technically outdated building that does not always support new ways of working or patient-safe requirement. The outbreak of COVID-19 also made us all even more aware of the fragile working conditions for healthcare staff. So the topic of today has never been more urgent. Caring for staff is caring for patients. And how can we as architects and designers support? My presentation includes 2 COVID adaptations projects that occurred in healthcare facilities we have designed: the NKS project and the O-House project at Karolinska University Hospital in Stockholm. Both these projects represent high future agenda when they were planned already back in the early 2000s, even though pandemic was never mentioned in that time. Karolinska Hospital is located on 2 sites, as you see here. Solna in the north with a brand new facility that was commissioned in May 2018, and Huddinge in the south with 400,000 square meter hospital from the 1970s. What you see on this image is our latest project, the extension. Karolinska was recently ranked during this pandemic year, 2020, as the 7th best teaching hospital in the world. So we are, of course, curious in what way did these new buildings support COVID adaptations? This is the site plan of New Karolinska Solna. 2 years before COVID breakout, 6,000 employees adapted their workflow to a more multidisciplinary context in a couple of new city blocks for highly advanced care in the same location where the existing hospital and the Karolinska Institute are located. The concept that was developed during the design competition were back in 2006 were based upon the following principles: proximity, generic and adaptable structure, division between acute and elective care, multiple external entrances, separation of flows, and attracting and healing environments. The structure is built to be rebuilt with a high floor-to-floor height, standard bearing capacity, decentralized shaft, double corridors, systems, and flexible floor areas. In April last year, the future-proofed agenda was challenged when we received the task to rebuild in an intensive care unit department from single patient rooms to 1 open pandemic theater for ECMO treatment during operation and in 4 months. ECMO stands for extracorporeal membranes oxygenation. In other words, the blood is oxygenated using the artificial lung outside the body. And this is the most advanced form of intensive care. And the objective was to improve staff collaboration with better visual control of each patient from 1 centrally located workstation. The challenge was to rebuild with ongoing patient activities next door and on the same floor. And it managed thanks to the built-in flexibility with double corridor, separation of shafts, and a facade grid. The rest of the hospital is planned for 100% single patient room, but it was already clear when the hospital opened the challenge according staffing in the most advanced intensive care unit environments. So, technical issues versus human needs. What I've shown you are very complex, medical complex environments. The high expectations of the architecture and design was already defined in the design competition with open and generous public environments, today restricted for visitors, of course. Nevertheless, the need for contemplation and distraction are more important than ever in the prolonged pandemic we now experience. With an option to take a pause in a relaxed, non-clinical environment with views, daylight, and beautiful artworks, and outdoor access to terraces and balconies. This is no rocket science, just common sense that could easily be forgotten in the complexity of delivering healthcare design projects. Next project, the O-House, Huddinge. So in April 2020, Karolinska Huddinge planned for the official opening of the new extension that had engaged us since a couple of years. It includes operating theater, intervention, and radiology. Instead, the hospital management ordered an adaptation on the 23 brand new theaters to 44 intensive care units in 10 days. The O-House project consists of 29,000 square meter high-tech environment with high demands on logistics and safety. Except technically advanced clinical planning, our challenge was to create a human environment that promotes health. So our tool were daylight, a rich color and material concept and art integration. The project includes landscape design with an outdoor gym, and this image I actually took yesterday. So here you see the double theater unit flooding in daylight, which is quite unique for the Scandinavian approach to bring all the theaters out on facades. This is also happening in the UK now. During the rapid COVID adaptation, each operating theater was transformed to 3 patient intensive care unit overlooking the preparation room and behind the hand wash. So this became a hygienic, staff and patient safe solution. The future-proofed objective was tested from start. As seen here, the position of ceiling-mounted equipment for operating procedures were possible to adapt for intensive care. The pass-through cabinets created smart logistic solutions for goods in a clean environment flooding in daylight. What in the building made this fast adaptation possible to transform to a safe and sustainable working environment? Double operating theater units along facade, double corridor system connected to the existing logistic concept from the 1970s, strategic location of shafts and sufficient floor-to-floor height. Again, the essence of distraction, feel-good environment has never been more urgent in healthcare design. To increase working conditions, so qualities as detailed of a wood railing or a courtyard with art installation. Who could ever imagine an artwork as a Venetian crystal chandelier in an operating theater department? It's unexpected, creates distraction, affinity, and simply joy. Nobody knows today what effect the pandemic will have on healthcare environments. If adaptation is the new normal, the human perspective becomes even more important to create a sustainable working environment for staff and key workers. So the lessons learned for COVID adaptation are many, but could be summarized through these 2 projects by creating multidisciplinary working environments through proximity, flexibility, and adaptability with generous floor-to-floor height and smart logistics. But most important of all, it's to create human spaces for contemplation with daylight and views for sustainable everyday life in the long run. These are some of the experience that we now bring along in 2 prestigious projects, the Oriel Moorfields Eye Hospital that we are developing in collaboration with ACOM and Pinoy Prasad, and also the Cambridge Children's Hospital that is now being developed together with Hawkins and Brown. And we are happy to bring our experience forward to the UK setting. And with this, I end my presentation with another lovely picture from yesterday on the park, where the staff is now starting to enjoy the outdoor environments. Thank you.
Thanks, Charlotte. I have lots of questions, but I think we'll save them to the end. And I also point out, anyone who does have any questions, can you please post them in the Q&A section? So now we're going to move on to Jonathan. The COVID-19 pandemic has affected health and care staff in extraordinary and far-reaching ways, with radical impacts on patterns of work, mental and physical health, and relationships with employers, colleagues, and the public. Jonathan will now present lessons learned from a multidisciplinary cross-sector study held by the European Health Property Network, conducted between May and February of 2021. In the study, a range of professionals from 15 different countries reflected on the contribution of the built environment in supporting healthcare staff in a multitude of ways. Jonathan's presentation will highlight how these lessons may affect future design choices in healthcare environments. Thanks, Jonathan.
Thank you very much, Michael. Thank you for the introduction. Just working out how to get my screen. There we are. Just move myself back to the beginning. There we go. Thanks very much, as I said, for the introduction. The project that I'm going to talk about is called Relocate, Repurpose, Reorganize. And you'll see from the first screen that during this project, we looked at 4 aspects of adaptation by hospitals in response to the pandemic: space, staff, systems and supplies. And I'm going to concentrate just on 2 of these today, space and staff, in the interest of time. So the project partners were, as you can see on the screen, the network that I represent, the European Health Property Network, but also White, the host for this session, Ramboll, the engineering company, and Walker Project, who specialize in transformational change in hospitals and health systems. So I'm not going to go through all of these goals. I just wanted to say that the important thing to take away is that we were really interested in 2 things. First, what were the different strategies used by hospitals in Europe and elsewhere in the face of the threat from the coronavirus pandemic? And secondly, of those strategies, what worked and what didn't? In other words, what really helped patients and staff in terms of their health and well-being, and what are the lessons for the future? So based on those thoughts, we focused on this theme of resilience around these 4 sub-themes: staff, systems, space, and supply chains. And to look at those, we held 4 webinars from May to December 2020 on each of the sub-themes, and then a final lessons learned webinar in February this year. The findings from those are on a dedicated website, and I'll give you the address at the end, so that you can look at all the detail in all its glory at your leisure. So, first of all, just on to space adaptation, transformation of buildings and what we learned from that. There's a huge amount to say, so this is, please understand, just a very quick overview and a bit of a snapshot. What we found from our many case studies was that the transformation of buildings, healthcare buildings, fell more or less into 4 different categories, at least in wave 1 and wave 2 of the pandemic. So the first one was, as everyone will be aware, a lot of transformation of non-healthcare buildings. We're all familiar with the Nightingale Hospital builds. The same things were happening in Madrid, in Rome, and many other countries, converting conference centers and sports arenas into healthcare-like environments. Fortunately, in most countries, those were not tested to the limit, and we felt that there were some doubts about the suitability of these environments for obvious reasons, not just for patients, but also for staff. The second strategy was to do with transformation of newly completed hospitals, and this is actually the picture that Charlotte just used from Hoedinger. So this is the typical reimagining of theatre space into an intensive care environment. That happened very frequently and very fast across many hospitals. And here there's a third transformation, which is taking an existing hospital and retrofitting part of it to provide a different kind of environment, in this case for infection prevention and control. And then finally, plug-in spaces, as we call them. That is all the tented structures that went out to control patient and staff flow, intended, of course, to be temporary and demountable. And for the most part, those have now disappeared. Lots more on those, as I said, on the website. Here's just some of the lessons learned. Charlotte mentioned flexibility. The possibility to section units from each other should be built into future plans. Charlotte also mentioned the importance of multiple entrances, something that I'm afraid has been somewhat neglected in recent design of some hospitals. And for me, at least, one of the most important lessons was how to rethink waiting areas. and the spaces for visitors and family who were so sadly denied access for considerable periods to the patients who were inside the hospitals. So all of this, of course, is intimately connected with staff and what happened to them during the first wave or two of the pandemic, and what is still happening in many cases. They saw some really rapid and radical changes to their working environments. We divided these up into 4 linked areas when we looked at our case studies, examples of what we call dislocation, isolation, the changes to working practices in terms of processes, and the new management structures. In other words, the actual human relationships between the staff, who they reported to, who they managed, how they got together in teams. In terms of dislocation, anybody who's been working in healthcare, or anybody indeed who's just watched the news, will be familiar with what happened to staff, that they found themselves often in very unfamiliar environments. Those operating theatres being repurposed is one thing, but of course the staff from intensive care have to get used to a very different environment. And beyond that, in the wider hospital, just the installation of things like one-way systems, reconfiguring social areas, public spaces being sealed off, have an immense effect on not just the processes of work, but the mental well-being of staff. Buildings, of course, were used very differently. So there were enhanced infection and prevention controls. Many hospitals had to instigate triage and testing in places where it would never normally be found. And there were lots of examples of wayfinding and routes being changed, which caused their own difficulties for many people working in hospitals. There were mitigations put in place. Focusing on the right PPE built some confidence, making sure that everyone understood what the protocols were around infection prevention and control, providing support for staff, and making sure that if they were to undertake a different role, then they should be appropriately trained to do so. Isolation, again, it's somewhat obvious that this took place, but we found it wasn't just within the hospital environment. People felt isolated even on their way to and from work. Those conversations that they might have on the bus or on the metro suddenly weren't open to them. The mitigations were hugely important, and we think have to be taken into account in future hospital design. We absolutely must rethink the social areas available to staff, not just inside, but also outside hospitals. And we've got to build solidarity across communities so that people have other means to communicate with each other because they don't have access to their usual social interactions. So finally, I won't take up too much time on this last slide, but it's just to say that we also looked at new working practices and the new management structures. There's a lot more in the case studies and the chapters that we built into the website on this. And I would urge you, when you have the opportunity, to go and visit it. It's hosted by our colleague Rambol, and it's full of, I think, very detailed and thorough research that will, I hope, inform future design for hospital environments going forward. And I'll stop there. Thank you, Michael.
Thanks, Jonathan. It's a fantastic piece of work. Thanks so much. I wonder if in the course of your research, did you have any sort of comments on the preparedness of the various different countries that you dealt with or you looked at? Were there vast differences, or was everyone starting from a similar standpoint of their expectations of what happened?
We got that information, I suppose, indirectly, because we asked somebody called Jeffrey Braithwaite, who's based in Australia, and he is the director, I think the title is the Australian Centre or Institute for Health Innovation. A very well-known academic and commentator, and he carried out early on in wave one a major study of 40 different countries, looking at the factors that affected their response to the pandemic, and preparedness was one of those factors. And his view certainly was that there was a very wide variation, even within what you might consider a kind of geographical unit like Europe. countries were very, very varied in the extent to which they prepared, not just for a pandemic, but for the right pandemic. So in the UK's case, we of course famously were judged by the WHO to be very well prepared, but the problem was we were probably prepared for flu, not coronavirus. In terms of the hospital response, I think our view we didn't have a huge number of cases directly from the UK, but from my perspective on the board of a hospital in the northeast of England, I think hospitals train so hard for crises, and emergency preparedness is part of what they do in their annual cycle of planning. So a lot of that actually kicked in almost seamlessly. I'm not saying it was easy. It was very difficult and very stressful for staff. But the idea of responding to a crisis of whatever kind was not alien. There was an assumption somewhere sitting in the background that sooner or later something like this would happen, and we'd better be ready.
Fascinating. Well, thanks, Jonathan. So we're going to pass on to our next speaker, who's so Kevin is going to talk to us about healthcare environments and how staff duties continue to grow in complexity, even with the development of telehealth and concepts such as the hospital without walls. Looking at how the modern healthcare setting can enable the staff-patient-visitor relationship to work in harmony to alleviate stress and strain for all, Kevin is going to explore the role designers played in this dynamic to allow the building to function efficiently while inspiring calmness and positivity. Over to you, Kevin.
Great, thanks, Michael. Okay, let me just share this here. Thank you very much. It's great to be here and to meet you all virtually. So yeah, Kevin Bates, Director of Scott Talon Walker Architects in London. And I really wanted to talk about certain aspects of the healing environment. And to set a kind of scene for this, it was interesting, I guess, to look at how maybe we've moved away from some of the early aspiration of buildings like the Palmio Sanatorium by Alvar Aalto, and that focus on fresh air, natural light, sunlight. And with the advent of very complex systems and technology and equipment, the focus on the technological aspects has kind of led us to a lot of people having the image of the hospital as being the crowded corridor, and a certain element of chaos associated with that. This has been addressed in many designs, and really the pandemic has been an accelerator, I think, of the need to reset our aims in terms of what a healing environment should be. And so, you know, you'll see from the amazing Karolinska project earlier, this is established trends that have really been accelerated now into because of the pandemic. And it's something we tried to bring to our Grafton Way building, which is the proton therapy hospital for University College London Hospital. We did this really by focusing on a very holistic approach, where we wanted to merge the physical environment with the smart technology and the digital environment, and all in a way that it supported the operational standards and ethos of the institution and the hospital, and to wrap all of this together in a very holistic design approach, always with the idea that this is focused on people-centered or people-centered design. And when we talk about people, we talk about the broad spectrum of people, from patients to the family and visitors, to the staff, and everybody that really has a role to play in the healing journey. In terms of the physical environment, obviously we looked very early at very functional and efficient layouts that cut down the travel time from nurse stations and bases to the bedroom and to the bed. We tried to create very uncluttered and calm environments, such that messages can actually be delivered, and that people are not snow blinded by posters and too much messaging. We concentrate a lot, obviously, on daylight, but the variance in daylight, so that we pick up on the circadian rhythms within our body, and we bring that daylight in different points and at different times of the day. We focus just as much on the non-clinical and non-technical spaces. We focus also on these non-technical spaces. So we look at breakout areas, we look at places that you can go to get away from the clinical environment. And we understand that the journey that the patient's family is going on is also a very traumatic journey. And so that they have a calm environment to wait in and go outside of the hospital potentially while they're engaged in this process. Positive distraction is clear, and it's well tested and well proven. And that's through the use of color and art, and even how wayfinding and the building itself can provide this positive distraction. Ideas around comfort and cleanliness. And when we talk about cleanliness, we're not just talking about infection control standards, but we're talking about the promotion and the enhancement of a clean environment, that it communicates a level of kind of comfort and cleanliness and security and safety. Control and visibility is obviously very important, and that there's the right passive control measures in place, that patients are always being observed in the right way, but have their own privacy and dignity as well. We look at areas outside of the typical healthcare environment, such as hospitality, even in terms of science and research, and how these can influence how we design very kind of specific environments. And we look at everything in terms of the people management, from the concierge service right up to self-check-in. And with all of this, it's crucial that the stakeholders are involved at a very early stage and right through the process, such that their feedback is incorporated, such that they feel an amount of ownership and responsibility for the environment that we're creating. And hand in hand with the physical environment, we also really focus quite early on the digital environment. So smart technology has really an important role to play in the new hospital design. The idea of digital twinning, so that you have computer simulations and models that can road test lots of different approaches before putting them into the live hospital, and so minimizing downtime. How data is collected, how it is used, how it is secured, such that it can help in the kind of the running and operation of the hospital. Putting GPS trackers on pieces of equipment so that it's clear that they and it's proven that they go through the sterilization process. User controls from their bedside so that they have a feeling of empowerment and control. Touchless controls and new technology is responding rapidly to the pandemic, and we'll talk a little bit about that later. And all of this driving towards comfort and well-being and the widening circle of impact of the healing environment. So that circle of impact is not just the patients, but it goes back through to all of the staff in terms of the information they receive, and it goes on further down to the visitors and the family of the patients, and the feeling they got when they went to the hospital and what they take away from that. There's lots of discussion about hospital without walls and healthcare in the environment and outside of the hospital, and how that will change the hospital environment. It's still developing. And haptic technology and neuroscience is having a role to play. And again, we'll talk a little bit about that later. All of this is to create an environment that really supports the operational methods and standards of the hospital. Patient safety and quality is uppermost, but we're aware of the staff challenges that have come about through the pandemic, and in some cases were there before the pandemic. We've talked already about the idea of dislocation and isolation that staff feel. Very interesting here to talk about that not being just within the hospital environment, but on the way to work and leaving work. And the amount of change and changing to work practices that staff have had to accommodate. And we can see this as being a continuous process. And so how does the building accommodate, how change and adapt to changing work practices? Lots of talk about the adaptable estate and feedback loops. So once these changes happen, how are staff dealing with that? What is their feedback? How can these be improved? A continuous kind of feedback loop. Tracking and data harvesting, staff, patient, visitor welfare. All of these are things leading to recruitment and retention of staff. And then at a macro level, the political impacts, particularly in terms of financing and the delivery of the healthcare environment. Items like patient transfer, how much that costs, the idea that transferring a patient from one hospital to another is a very expensive process. And so putting all these together, I think it's very interesting that kind of an idea at the moment that the pandemic has driven us towards a kind of more touchless reliance maybe on technology. And how does this balance with a greater understanding in the idea of research in neuroscience of the benefits of face-to-face interactions? And this idea of things that people like Giovanni Palesmo talk about, the eyes of the skin, that we don't just rely on the predominance of the visual sense, but the role that hearing, touch, smell all have in terms of our human-to-human interaction, and the role that that has in the healthcare environment, and how we're going to balance that amount of research, the benefits of that, with the kind of risks associated that have come out of the pandemic. And so this is kind of hapticity is really what we're talking about, haptic technology versus face-to-face. And, you know, there are architects like Peter Zumthor, who, with his Serpentine Pavilion, really distilled the essence of a garden and the role of the garden in terms of providing a breakout space, a kind of meditative space, a quiet space, the touch, the smell, the feel of the breeze blowing through it. And the neuro-architecture of his Swiss sandbox, where the movement of the timber and the sound of wind through that timber and the smell of the lumber all feed into the sensory appreciation of an environment. And there's lots of evidence supporting all of this in terms of its healing benefit. And it would be interesting to see how we accommodate both these strands of the rapid increase in technology with the more kind of human face-to-face interaction. And so that's the end of my presentation today. Thank you very much.
Thank you very much, Kevin. Really, really fascinating. In the interest of time, I'm going to just carry straight on with Ruth, and we'll take any questions at the end. So for our final speaker, we have Ruth Charity. Over the past year, the environments in which hospital staff work have held even more importance, and the role of art to support staff, patient and visitor well-being is being more widely acknowledged in hospital trusts than ever. Focusing on a new programme of artwork for the John Radcliffe Hospital's ED Resus extension, Ruth will discuss the way in which artists can contribute to the creation of environments that support staff as well as patient well-being and the increased focus on biophilia in hospital art programmes. Over to you, Ruth.
Thank you very much, Michael. Well, I'm a curator. I also run ArtLink, which is the arts programme for Oxford University Hospitals NHS Foundation Trust. And we've developed a broad range of integrated arts projects over the years. Wherever we can, we try and involve artists at early stage discussion and in the design of entire environments. Our aim is to create hospital spaces which support patients and visitors, but of course of equal importance is to provide positive working environments for staff and support their well-being. Staff spend long days in hospital wards and departments, and the environments in which they work can have a huge impact. This is even more important when the pandemic has left staff exhausted and stressed and morale is low. I'm going to talk about a project that we installed over the pandemic to illustrate the role in which artists can play in creating a positive working environment for staff. This is the extension to our emergency department at the John Radcliffe Hospital in Oxford. And it's a small scale project. It included 8 bays for seriously ill patients, a paediatric resuscitation room, a CT scanner and control room, and then spaces for relatives and a room for the deceased. For all the arts projects that we work on, we start with a steering group of clinical staff, and here we worked particularly closely with the deputy matron for ED and also the CT radiology superintendent, and obviously the architect and design team and our capital programs team. It's really important to involve staff in early stages, as Kevin was saying, to build that ownership, and also because they are the ones who know the needs of patients and also the needs of their fellow staff. Emergency department is a high stress environment, so the overriding aim of the art programme was to create a calm yet positive space. And staff were really keen to bring colour into the department and also to use art to distract patients who may well be anxious. The first artist that we brought in was an artist, Jackie Poncelet, and she was appointed to look at colour throughout the department. She applied her colour scheme, which was based on the colours of nature, across a range of materials already specified in the plans. These are samples of her colour range for wall protection. The original plan for the building was grey walls and dark walnut doors, so it was really important to bring more positivity through colour. Jackie's colours are bright and positive, transforming the space. She also specified colours for doors and splashbacks for sinks, and deliberately selected quite a strong palette that would compete with the ordinary everyday clutter of a working hospital environment, the bright yellow bins, the colourful trolleys. She used colour also to aid wayfinding, so stronger colours were used for doors that were accessible to patients and their families, and then quieter colours for private spaces. And she selected all the furniture for the department, specifying designs and colour. This is the room for the deceased, where relatives go to view their loved ones, a really stressful space. And Jackie also selected some of her own artwork for this space, working very closely with our hospital chaplains to make sure that it was suited to patients of all faiths. As you can see, Jackie's work is based on colour and pattern. And it's this deep understanding and knowledge of colour that artists use daily in their work that makes certain artists like Jackie ideally suited to this role of bringing colour into spaces. The second artist that we worked with, who also worked with Jackie, is Una Cully. She created an integrated programme of artwork based upon a series of beautiful watercolours of leaves from Oxford parks. Her choice of the medium of watercolour, with its natural luminosity and subtle colour, was ideally suited to the brief. Her paintings for ceiling-based light boxes reflect the pattern of overlapping oak, beech and ash leaves with sunlight behind them, as if you're looking up at the sky. This is a light box above a CT scanner where patients may be stressed and anxious. She therefore incorporated birds to count as a distraction tool for patients. A second ceiling light box was developed for the paediatric bay. And this is used for children up to the age of 16 and occasionally, when the department is busy, also for adults. So it was really important that the imagery was appropriate for all ages. Again, they're animals and birds to spot and count. And this was an idea developed through her dialogue with play specialists. She also created artwork for this sliding door to the paediatric bay, which has a functional aspect as well. At the base, the design is opaque and transparent at the top, so maintaining privacy for patients, but also allowing transparency so that staff could see in. She extended her brief because staff were so interested in her work for a space for patients with mental health needs. Patients using this room can be agitated and disturbed, and staff report that the artwork plays a really important role in reducing stress and calming patients. Much of Una's work was directed at patients and supporting them, but it's also about creating a rather beautiful environment in which staff can work. And of course, if you're supporting patients, you are also supporting staff. She also created a series of ceiling tiles for bays so that all patients had something to look at. And a large frieze that sat above the staff base, which also aided wayfinding, drawing attention to that base. There's one work that was created just for staff, and this is in a very small claustrophobic space of the CT scanning control room. The radiology superintendent was very keen that staff would have, that work here would have, the radiology superintendent was very keen that staff would have work here that not only made the space seem larger, but also offered some quiet contemplation in a very stressful environment. During the last year, much has been spoken about biophilia and the innate tendency of humans to seek connection with nature. I'm sorry, my dog is also contributing to the presentation. Since the 1980s, there's been growing research from Roger Ulrich and others on the role of nature in supporting patient recovery. And more recent research shows that even looking at images of nature can lower blood pressure and stress levels. Although we've yet to undertake a formal evaluation of the art programme in the ED Resus department, informal conversations with staff bear this out. Staff say that the artwork makes them and their patients feel calmer and that it's a beautiful place to work. And following on what Kevin was saying about other senses, the one thing they say they need now is some birdsong. Thank you.
Thanks, Ruth. Okay, so now we're going to open the floor for any questions. One sort of quick question I have for you, Ruth, is really your presentation shows, I think, the importance of artwork, but also the opportunities for art without, very large costs, just through very careful curated color selection, for example. I wonder how you go about ring fencing that within the design process.
I think it's very much about early involvement, and all the work shown there was funded by our hospital charity. So it's convincing staff and convincing the charity that it's of value, and having those very, very early conversations with architects and design team and staff. The cost to changing the colour scheme was the cost of a few days of an artist's time, but it made a huge impact. And so we're trying to do this more and more often. Sometimes you work with architects who are fantastic on colour, and sometimes architects feel that that's not their strength. So it really depends on who you're working with.
Grey walls and walnut.
It's pretty, and it's an environment with very little natural light.
Yeah.
So it was quite a dull space to start with.
And then just going back to the beginning, Charlotte, I was thinking during your presentation, obviously Karolinska was designed to be the sort of ultimate generic flexible hospital, but in the course of these transformations for the pandemic, was there anything that was stuck out as being forgotten or a missed opportunity?
Of course, yes. I think, this was a huge project, 330,000 square meter new facility from scratch. And also what is interesting with this project is difference in the stakeholder process, because in the Karolinska, it was a reference group and not the final tenant that was actually moving in when the hospital was taking in commissioning. So of course there were lots of opinions, and what has been interesting with reflecting over the pandemic now, and it was also very criticized for different reasons, how it was taken care of, this management and the change of workflows. But what has been interesting now is that the pandemic actually, from what I experienced, has accelerated the speed to realize the benefits to actually work in one environment instead of spread out in 40 different buildings. That was the situation when the decision was to merge it into one facility. And I also think, referring to this subject here today, that it was a large project, but thanks to that, it was actually the start of the project was a design competition, an architects competition, set the values and the goals and the objectives really early, that became a very strong support for us while navigating through this rather jumpy journey that it has been. And there were, I think also right in the middle, it was decided to be procured as a PPP project 2 years after we had won the competition. But thanks to the design competition, the architects competition, the client was quite strong in their understanding which question to bring up in the forefront, and where actually the expectations on architecture, art, design, lighting, and were strong. And it was definitely also thanks to the evidence-based design movement that also had a strong influence in the 2005-06. For instance, Roger Ulrich was also in Stockholm and gave the message what counts from a human point of view in the long run. So back to your question, it wasn't perfect from start, and there has been lots of discussion and opinions what was missing. Example of areas for administration and some key functions. But I think if you would interview the staff today, that the benefits to working in one integrated multidisciplinary environment benefits the need for adaptations that we see is becoming more and more important.
Mm. Kevin, do you have anything to add on sort of how the issues of adaptation and adaptability are affecting your current projects?
Yeah, well, I guess there's two ways of looking. There's short-term adaptation, and then there's long-term adaptability. And so very much now we are looking at, as part of the circular economy and everything else, we're looking at buildings that can be repurposed. So the idea that you demolish a building in 50 years and rebuild a new one is really not something we want to pursue. We want robust, simple buildings in a way that can be adapted for multiple use. So on the Grafton Way building, it was a 9-meter grid. It had floor screeds and voids on every floor to allow for future flexibility of services. The servicing strategy took account of all of that. Interestingly, that approach was all worked hand in hand also with a fully glazed facade. So the idea of creating a fully glazed wall to the bedrooms was not only about the light into the bedroom, but it was also about creating a facade that the building could be changed into an office environment, for instance. So these things open up opportunities that in some cases propel you along to create better healthcare environments, even though you're maybe in some ways thinking about something else. But it's, there's no discussion anymore. Buildings have to be adaptable, they have to be flexible on multiple levels. And it's like the discussion about sustainability 20 years ago. It is now just a part of what we do.
Mm. And Jonathan, I was wondering if you had anything to add on. I mean, the healthcare estate in the UK is quite diverse. Comes from from Victorian 60s buildings, 80s buildings. Have you got any reflections on that and adaptability, and then also on the question of sustainability in terms of the amount that you demolish, the amount that you rebuild, how you consolidate these estates in the way that Charlotte suggested?
Yeah, I mean, perhaps I could give a bit of perspective from some of our other members of the network. So, I mean, I'm speaking in very broad terms here, but I think it might be fair to say that there are some countries, such as the Netherlands, where the idea that you invest in a building for 50 years and then you knock it down and you build another one is not unfamiliar. I mean, that's been quite a theme in that part of the world. I contrast that with what our Italian colleagues say about flexibility and adaptability. I had the opportunity to go and visit the Sant'Orsola Malpighi Hospital in Bologna 3 or 4 times. That at its core is a medieval structure. I mean, it's a building that I think was built originally in the 15th century. I may be 100 years out, it might be 16th century, but it's all still there. And actually, it functions very well, not as a clinical environment, but as an administrative block. But of course, surrounded by a campus of buildings that have grown up over time. That brings its own complications, but it does means that in a strange way, they've got a choice of environment and they can move services around to that which seems the most appropriate. But more generally on adaptability and flexibility, something else that I picked up is that it perhaps isn't just about the built environment, or rather it's about how the built environment responds to what is decided in relation to the services on offer. So, for example, I think the experience of the pandemic will probably move people again towards the idea that we have to have separation of elective planned services and the acute and emergency services. Whether that's separation on the same site or across different sites is up for discussion, I suppose. But from personal experience, I certainly think that keeping frail elderly patients in the same building as people who are acutely ill with an infectious disease probably now is not seen as the way forward. So we may have to rethink the actual division of these.
And then lastly, on a slightly different track, I thought Ruth's really interesting, the discussion about biophilia. Obviously, the project you showed was a interior project, but have you looked at any sort of landscape, using artwork in the landscape as a sort of external space, particularly perhaps in relation to staff? And
there's more and more discussion about garden spaces, and one of the problems is maintenance. So we're just about to start a project for a garden for older patients, particularly those with dementia. And there are a number of projects across the country, some lovely projects that are garden-based projects. But our trust struggles with the funding for maintenance. So it's always a big issue. But I think they are really, really important spaces, that particularly at this stage, and the need to get patients out of wards and into, just for a short space of time, into a green space, I think is really important.
Great. So we have a few questions that have come in. One from Maria van Heel, which is about the specific point on the Netherlands. Does anyone recognise that we found in the Netherlands that hospitals still had spare space / wards sitting underused after relocation, which were a large advantage to repurpose these wards into surge capacity? Charlotte, did you want to pick that?
I have to read it one more time. That was in it.
It's about additional space that is available for surge capacity.
Advantage. Oh, I just have to.
Jonathan, maybe, did you have any thoughts on that? You're muted.
Yes, sorry. Yes, I do. Only from personal experience, the hospital that I'm associated with works across 2 sites. And we did indeed find that what we called the cold site, which is a horrible term, but the site we used for low risk surgery had quite a lot of available space. And that suddenly became immensely important. Although it couldn't be used immediately in the first wave, once things had been reorganized, it came into its own. And it now means that we're able to cope with the recovery from COVID, if not the pandemic itself. It means that the backlog of waiting patients can be processed more efficiently, as long as you're willing to put in place the measures to ensure that should anything happen during their surgery, they have timely access to the hot site where we've got the intensive care.
Could I add, now I had a chance to read it twice or 3 times, but we see this possibility and this need. But what you're talking about, Maria, is also to transform wards with surge capacity. And this is the reason why, for instance, NKS was had a high level of technical installations, as I told, the decentralization of shafts, etc. So we had this discussion really early. How far can we go? And we decided that the wards on the top floor could never be operating theaters, because that required so much ventilation and technical installation. So that would never happen. So they have a lower technical standard, while on the levels up to intensive care units, these are possible to transform into operating theaters.
Great. Well, we've just about reached our hour, so I'd like to thank all of our speakers for your contribution and discussion. Very fascinating topic, lots more to discuss. Unfortunately, we've reached the end of our time for this webinar, but thank you all very much and look forward to meeting you all again soon. And thanks for all our listeners.
Thank
Cheers.
you.
Bye.
Thank you.
Bye-bye.
Bye.